Can you hear me now?
Yes, I can.
Perfect. I can as well. So we're good. How are you?
I'm good. Yourself?
I'm good, thank you. Thank you so much for taking the time. I understand you're still working as an
Yeah.
essential worker.
Yes, I am.
How's that going?
Yeah,
Busy?
it's going. It's going all right. Yeah, it's busy enough. Yeah, so it's just been an interesting year all around, I think.
I can imagine quite a lot. Great. So the reason I wanted to talk to you is I've had a chat with Angus, one of
Hmm.
your colleagues and
Yep.
former colleagues, and I want to have a discussion around fascia.
Hmm.
I don't know so much myself. As I explained, I'm a massage therapist, so I'm not
Yep.
into sport therapy.
Yep.
And I can see fascia getting into the fitness industry a lot.
Hmm.
So would you be okay just to begin with, explaining, for example, the difference between fascia, trigger points, and scar tissue, some terms that get thrown out there all the time?
Yeah. Well, I'll begin to talk about fascia as a in terms of the mechanical model to start out with. So when I first sort of came, I wouldn't say I came upon fascia. Um, so when I was in chiropractic school, so we had gross dissection anatomy. So we were taught about what fascia was, what at the time they thought the function of fascia was. When we dissected the cadavers, uh, you can really see how the skin is connected, to the muscle underneath. You sort of have this little space with, and a cadaver just appears to be as fluff, basically, um, and attached to, the deep fascia, which is more tough, especially the fascia around the thoracolumbar fascia, the iliotibial band, the fascia around the gastroc and the Achilles, etc. That's quite thick and quite almost like a burlap sack, basically. So at the time when I was dissecting it, I just viewed it as it seemed like there was more to it at the time. When you pull up on the skin, not only do you see the blood vessels, but you see all the cutaneous nerves that serve the skin, penetrating the fascia, going up through the skin. So I was always quite fascinated, by that. But we just sort of like cast it aside. We learned the muscles underneath, all the structures underneath, and so on. So that was always in the back of my mind. And then it was around 2006, I think. I was working with a physical therapist in America, as physiotherapists are called. And he had the first edition of Thomas Meyer's Anatomy Trains. Um, Back then, I believe the book had no color pictures. It was just all black and white drawings and everything. And I became interested in it. So I sort of delved into it for, picking it up, putting it down for a few years, and then got into it a little bit later on, maybe around like 2008 or so, 8, 9. Started looking a little bit more deeper when the second edition came out, and I felt there was more to it. Then they thought of fascia as more of a mechanical structure, which there is still a mechanical structure. Um, and they talked about things in soft tissue courses, and they still teach this. They talk about things like adhesions, trigger points, scar tissue, and so on. But as I've gotten into a little bit more pain science and just through my own research and things, and how the research is progressing now, is it appears that it's not only a mechanical structure, but there's more to it as a neurological structure. So those cutaneous nerves, and also in that interstitial layer is mechanoreceptors like Pacini, Ruffinian endings, Merkel's disc, etc. So I view it in terms of my practice now and how I teach it, because I teach for Rocktape. Um, I view it as more a neurological organ than a mechanical organ.
One,
Of
yeah.
course, I believe it's a mechanical organ in terms of um, processing or propagating forces and things like that. But I view it as how I can impact it or how manual therapists can impact it. It's more in terms of uh, I'm having a conversation with the brain as opposed to breaking up scar tissue, breaking up adhesions and things like that.
Okay, so you believe that in order to change that function of the fascia, you promote active, so let's say active movement, or more of a neurological approach than as you would a more passive breaking of tissue or stretching.
Yeah, exactly. So, I mean, I think the most powerful stimulus you can have, to the body or to the fascia or to the brain is movement and moving in a lot of different ways, moving with various loads, providing stimulus. That's the most powerful stimulus that you can have. But as a practitioner, what you could say passive treatment, I am going to provide stimulus to the tissue. So, but I'm not providing stimulus to the tissue from the standpoint that I'm breaking shit up. I'm providing stimulus to the tissue, getting the body to feel things more, have a conversation with the brain. But that's only the beginning. If I'm not moving them afterwards, I'm not going to have the impact on it. I believe one of my colleagues likes to say uh, you can't fix an active problem by passive treatment. So I always use movement as the most powerful stimulus, with that patient.
Yeah, so that's very interesting because my main component is Pilates and yoga and flexibility, and I work with people that want to do the splits, they want to do high leg, exaggerated joint positions, and we see a shift now that everything is shifting into loaded stretching.
Yeah.
While in the older days it was just spend 10 minutes in as far as you can every night. Well, now it's more like, can you activate the muscle? Can you actively go into the position? So it's very interesting to hear about that. So sorry.
No, go ahead. Go ahead. Yeah, go ahead. Yeah, you can go ahead.
So how much do we know about fascia? As you said, we used to kind of throw it around in the older days. Wasn't it something unnecessary in the body when we dissected people?
I mean, I think we know more, but we don't know enough. There's, I think was it last year or 2 years ago, they did some research and they identified an organ that they didn't know about called the interstitium. So that space in between, the skin and the fascia, they call the interstitium. And the theory is that's how your body, exchanges nutrients, cancers spread, and so on. But they say that you can only view it in living tissue, like in a cadaver. That organ is dead, and you can't truly view it. I think we're on the cusp of learning a hell of a lot more. There's also the theory that that space between the fascia and the skin, the superficial fascia and the skin, there's also exchange fluids that provide a surface tension and allows gliding between the tissues. I feel, at least my understanding of it, that gliding between the tissues is important because the more the glide is allowed, the more stimulus we're going to have, to those mechanoreceptors, ultimately that stimulus to the brain. So we used to think that joint position sense and proprioception was more of a thing at end ranges, but it's the skin and the fascia that's going to give you that feedback, everything in between. But what happens is when somebody has movement limitations, have somebody have an injury, what happens is that how much you move in that range of motion, that envelope of function gets, considerably smaller. So when that envelope of function gets smaller, that's the brain's not going to get the stimulus, the full stimulus. And then the body views that as threat, inserts pain in to protect. So I think we need to, I think where things are going is in terms of, the fluid exchange, more of the fascia as a neurological organ than anything, in my opinion. But, the research has to, progress toward that, which it appears that it is. Like Dr. Robert Schlepp has contributed a lot of research in terms of the mechanical deformation model versus the neurosensory model, and the fact that we can't really break up fascia. So how fascia is represented in the manual therapy field, a lot of people still are saying that, I'm breaking up adhesions, I'm breaking up scar tissue, I'm releasing trigger points and things like that. And there's even some question on whether or not a trigger point is really a thing. Is trigger point really more of just sort of a neurological, tightness than anything? But I think in terms of manual therapy, your intent matters. So if you're going in and thinking you're gonna break up shit, your approach to the patient is going to be a lot different if you're trying to stimulate, have a conversation with the brain. So there's two different approaches. If you're going to go in there and think you're going to break something up or release trigger points, your approach is going to be a lot heavier versus if you're trying to, provide a conversation with the brain, your stimulus is going to be a lot different. I think that, I'm really excited about, where this is going. In just the last few years, things have, got changed, quite a bit.
That's great, and I can see what you're saying, because physiotherapy seems to be going that way as well. So we see physios to be less and less hand-on, and trying to provide more active activation through the injuries through the joints. So how do you find that it's helped you? You're a CrossFit athlete, so your body goes through a lot in the year.
CrossFit. I think, look, CrossFit can have, I think in a lot of ways, CrossFit, they're sort of the good end of CrossFit, and then there's the other end. So, and a lot of it's a difference between, somebody who uses CrossFit as exercise versus as a fitness modality versus somebody who competes at CrossFit. So generally competitive CrossFit is I wouldn't say long-term is something very healthy. Just like any type of elite sport, competing at an elite level isn't necessarily healthy. But I think where CrossFit excels at is the fact that you do a lot of different movements, whether it is weightlifting movements, cardiovascular, plyometrics, gymnastics, body weight movements, etc. You're doing it at different intensities, different time durations, but then you're also doing it at different loads. I think load is crucially important. I think a lot of people have been afraid of loading the body via weights and resistance training, when that's a very powerful form of neurological stimulus. Not only is moving in a lot of different ways and doing a lot of different activities, but a lot of different loads provides another type of stimulus. But then also the skills, the complex movements and the skills that are used in CrossFit, like a complex movement like an Olympic lift, or a gymnastics movement, like whether it is like a handstand or handstand press up or a chest to bar pull up or something like that, that the need for skill is going to provide that neurological stimulus, create that neuroplasticity. But on the other end, if you're doing if you're providing too much stimulus to the body, spending a little bit too much time in that sort of that sympathetic state, you're going to have that negative load and that overtaxing of the system. But in its purest form, I think CrossFit can be, quite beneficial to a lot of people. I'm nearly, I'm going to be 50 next year. And I've been doing it for I think about 8 years now. And I feel that in terms of the variety of things I do, like if you talk to me when I was 39 years old, I was mostly doing like weight training, bodybuilding type stuff. I would do a little bit of functional training, but not, nearly as much as I do now. And I'm probably, in terms of how I feel that much better now than I did, 10 years ago. But I think the social element of CrossFit is quite beneficial as well, because one of the reasons why it's beneficial to move is because we're social beings, which has made this year, very challenging because, all of a sudden we're told not to be social.
Yeah.
But also, I don't know if you found this with your clients and I found it with myself, is because, we're confined to the home a little bit more. We're not, gyms are closed and things like that. Our world has gotten very small. Our, perimeter where we travel to has gotten really small, but also we're like this all day, and getting
Exactly. Yeah.
opening up is something we're not doing. So I found, certain challenges with myself during the first lockdown, and, not being able to, do some of the gymnastic stuff and things like that, and realizing how beneficial that was, for me. So yeah, this year has been, quite interesting. And then also taking away that human touch. So you alluded to, you talked about how, manual therapy, physiotherapy, et cetera, has moved a little bit more toward less hands-on, and more movement-based, but also more the psychosocial component. But I still think that therapeutic touch that manual therapists provide is still important, especially now that we're not getting that,
Social element.
that social touch, that we get on an everyday basis. So I think the bio still matters, um, even though we're emphasizing the psychosocial a little bit more. The bio, the touch, and sometimes that touch, just creates that comfort with the patient and creates buy-in. Especially if you're treating like a chronic pain patients, et cetera. I mean, I get a lot of people who, especially now that NHS physios are mostly online consults now, is patients, want that physical treatment a little bit more, eventually. But I might do a little bit more manual treatment in the beginning, but then I'm as I go through the treatment continuum, I'm going to emphasize the movement more as we go on.
Yeah, and I think it's important because, I mean, your stuff, so it's important that you educate the people, that saying them like, look, I'm doing this for you now, but then you're going to have to do something about it.
Absolutely.
Yeah, great. So a note on CrossFit. I must say, CrossFit has been amazing in removing the taboo of lifting for women, which has been great. And it has introduced, like you said, Olympic lifts and gymnastic muscle ups, a lot of good stuff that people would benefit if they took the time to invest in it. Because I have a similar story to yours. I was always doing like bodybuilding type stuff, and then I got into dancing, and I've done pretty much everything in the fitness industry. Now, regarding what you said that CrossFit offers a great variety, not only in loads, but also in movements. When it comes to my profession, a group exercise instructor, he's going to be teaching, let's say, the same class 5 times in a week, doing more than 500, 600 repetitions per class. Moderate weight, so not really heavy. But I'm noticing a pattern of, I'm not going to say specific classes, but let's say if in a class you're doing 5 minutes of squatting, which equals to about 200 repetitions going up and down. Most of them half range, not even a full range squat. How does that impact the joints in the long term? Even if you don't, if you think I'm not lifting heavy, so I'm not going to hurt myself.
I'd like to, like, well, one thing when it comes to movement, I definitely don't, I think there's a when I first, so prior to becoming a chiropractor, I was a personal trainer for 10 years. And when I first started personal training and first started bodybuilding, et cetera, they used to always say, oh, don't squat past parallel because, you know, you're going to, it's harmful for the knees and, you know, like that. I think it's important for people to squat to where their body allows and try to expand on that. When I first started, since I was doing years of bodybuilding, when I started at CrossFit, I had to realize that I had to squat deeper, and even now I still struggle with that due to past knee surgeries and things like that, because my body hadn't quite felt safe, you know, squatting as deep. But then also everybody has unique, you know, joint characteristics, you know, or femur lengths, and, you know, the ability of the ankle to dorsiflex and things like that. So I think it's important to, you know, find out where a client's limitations are and then try to expand on that, because full range of motions is still important. But it's more about letting the brain feel safe doing that. So even at low weight and squatting a lot, squats are actually a very fundamental movement pattern. Everybody should be able to do it. But I also think the industry creates a little bit of movement shaming, you know, so to speak. Like if somebody can't squat the depth, there's a lot, oh, you know, oh, this is wrong. You have tight hips, you have this, and this. And then they think they're broken, and then they have to go somewhere and fix it. Or some people get really fearful of the movements because they go like, oh, I can't squat that deep because I have tight hips, you know, so then they're less likely to do the movements. So one thing that we teach, Rocktape has a new course called Movement Specialists, and we talk, in the first day we talk, everything's based on the squat, and we talk about analyzing movement, and the first goal is, can you perform the movement? Yes or no? And then the next thing, you know, can you do it? Can you do it well? Can you do it smoothly? Can you do it with control? So the first goal is always, you know, can you squat? But then, can you squat? You know, can you own it? Can you squat with control? Can you, you know, squat properly? And then you can add load in order to, you know, expand on that. So but in terms of, I think a lot of people have gotten, or people think like, as I get older, I can't really squat heavy, or I can't, you know, I got to keep the weights light and just do, you know, high repetitions. But I think that load is really important. It's just a more powerful, you know, stimulus. So if you're doing a lot of high rep, low load squats, you know, then, you know, maybe a little bit moderate weight, moderate rep squats, you know, so there should be a variety of things.
What about if it's your job? So my job as an instructor, let's say I have to teach 5 classes a week, where like more than 1,000 repetitions per class. Is that going to take a toll on my body in the long term? And can I do something to revert that?
Yeah, so I've actually I've thought about this. This was a few years ago. I was actually working an event. I was working a Les Mills event. And
I didn't want to say the name, but there you go. You got me.
No, but not. I think Les Mills is. I'm like amazed at like the fact that instructors can do as many classes a day and, you know, things like that. One of the beauties of being a CrossFit coach was the fact that you don't necessarily have to do the whole class, or you don't do the whole class. You're just there coaching.
Okay.
So I would probably try to find some way in order to, you know, maybe not do so many repetitions and do a little bit more coaching in the class. if possible. I know that
Mhm.
certain class models and things like that, because I'm amazed at like Les Mills instructors and the fact that they can do, the whole class with the people, hour after hour, day after day, because that is going to give you a lot of like wear and tear. Uh,
Mhm.
I actually don't want to use that term wear and tear, but it is going to put some stress, a lot of stress on the body.
Yeah.
And especially if you're in a standpoint where you like to do some things for yourself and not that affecting the capacity to do the things that want to do. So that is a difficult challenge. I've treated, yoga instructors who, not because of yoga, but they might have, hurt their knee or back or, what have you. And, for a few weeks they had to, not, do the movements with their clients and their class attendees. So it can be quite, grueling, in terms of having to do the movements. Because I
Yeah.
could imagine like coaching CrossFit and, doing the actual class with my uh, with my athletes, all the time.
Oh,
But yeah, so I think that is a unique challenge, and I guess it's just finding little micro breaks in it for yourself, even if it is just going around and coaching people a little bit.
yeah.
Um,
That's great advice. Perfect. So you said you're a personal trainer. I was a personal trainer as well as when I did my course,
mhm.
and this is the main reason why I wanted to talk to you. So there was one piece about foam rolling, which is referred to as myofascial release.
Yeah.
And that's the main thing. Is foam rolling myofascial release? And if not, what is it?
Well, I think myofascial release has been, yeah, that's been a term that's been, I don't know if it's been used. Yeah, I don't like the term release
Okay.
because mainly because, yeah, some things are tight. Yeah, maybe some things need to be, released, but then also some things need to be stimulated. Some things need to be switched on. So what foam rolling does from a neurological standpoint is just provides a neurosensory stimulus of the skin. Affecting mechanoreceptors underneath the skin and embedded in the fascia. And it just provides a stimulus to the brain, allows the brain to feel the area a little bit more. When it feels the area more, it creates it can create a little safety. Um, and and I think people think it with that release, or you're breaking up adhesions, you're releasing trigger points, things like that. I think sometimes that verbiage makes you think that something mechanical is happening, which isn't 100% accurate. People foam roll their quads and iliotibial band, which really they're probably not really you know doing anything. They're not doing anything mechanically to the iliotibial band, but they feel better afterwards.
Yeah.
And that's just increases some tactile acuity, creates some safety, might increase range of motion. So it's not a bad thing. I still people feel better after doing rolling around on a foam roller, and I definitely advocate that as just a little self-care. Like I would probably say before movement, but before you know exercise or run or whatever, doing a little quick light rolling just will provide a little tactile stimulus. Afterwards, you can do a little more slow, deeper roll, but we're not really breaking anything up, breaking adhesions, things like that. But also the thought of, oh, well, I'm going to release fascia or I'm going to break up these adhesions, that also communicates to the person that the body is fragile. So thinking that you're breaking stuff up, makes it think that, things break easily, or,
Yeah.
that we're a pliable, piece of clay, when that's not 100% accurate. If you hold the iliotibial band in your hand, it's thick, and there's not much that's going to, change that. Um, but it's tight because it does help in that spring mechanism, and when you're running and jumping and things like that. So I think we're just providing sort of just a little neurosensory stimulus. If we were going to break up fascia, our skin's going to break a lot sooner than the fascia, but the touch of the skin and providing stimulus to the skin, can be a very powerful, sort of neurological tool. It can give somebody, comfort, and treatment doesn't have to be painful, because pain is threat. You might have some, tender spots and, patients and things like that, but also during treatment, like you were talking about, it's about educating the patient. So sometimes you could use that touch to educate your patient or client. So, but I think it's more of it's a neurological thing, or like that's what I think is going on, right? Where the research is pointing us to.
That's great. So do you think it's easier to kind of sell the foam roller, the peanut ball, the everything as breakers rather than stimulators?
Yeah, and that's probably why it's sort of progressed, to that. It makes sense, like in terms of people think that they can, that they have a spot, they have a trigger point, or they have scar tissue. We're just going to break it up and everything's going to feel better.
Yeah.
That's something that you could really visualize. But talking about the brain is a lot more difficult. Or if you talk about the brain, sometimes it's like a couple of months ago, I was talking to the patient, and I was explaining the concept of brain smudging, which Mosley and Butler talk about, in terms of improving that. If you don't feel an area well, it gets blurry in the brain. So then that's threat. Body inserts pain to protect, but also if a body part's blurry, then you can't move it too well. So that's a little bit harder to explain to somebody. But then as soon as you say brain, everybody gets scared. It's like, oh my God, I have cancer or something like that. Or people will say, oh, well, it's all in my head. Which that's not the case. Pain is always something they're experiencing. Pain is something that is very personal to that person. So yeah, but a lot of people have been told, oh yeah, that somebody who has headaches, oh yeah, it's all in your head, or oh, your back's not that bad, or they've gotten a scan and oh look, the scan's not that bad, but then they experience a lot of pain in the back. I had a researcher, a patient of mine who was who had done a lot of research in another area of medicine, and he said you cannot deny pain in the research. He says, because pain is something the patient's experiencing. So you do have to be careful in saying that, you have to empathize with the patient about that pain, but it's just really important not to catastrophize that pain.
Yeah.
We just, all I'm trying to do is create safety in my patients to get them moving better, to improve that envelope of function. But then once I'm able to increase that envelope of function, they're able to move in a lot of different ways. That's going to create safety, and then they're more likely to, decrease pain. You can call it placebo or whatever, but we're still having an effect. If I could create safety and allow them to experience world and life a little bit more, I think I'm, going on the right track.
Yeah, no, it's very important that you say that, because I see that with a lot of Pilates clients that I have.
Mm-hmm.
And when you try to educate them and bring about them, just kind of hand them over the responsibility.
Yeah.
They feel so much better rather than you telling them what to do and how to do it. It's more like, what do you experience when you do that? How far do you want to go? And it kind of creates that self-confidence in them to go further. As you probably have with a lot of your clients, you said you're nearly 50. It's,
Yeah.
and so I get that with some clients who are, I won't say in the older spectrum, but they feel old themselves.
Mhm.
And they come to me with that sense of, oh, I'm just old. This is how it's going to be. I've had this back pain for I don't know how many years. This is how it's going to be. How can we approach a client like that? So how can we, like, because I know I can make a change, but they don't know it yet.
Yeah.
In a good way. Yeah.
Like how I like to address that is I always, well, first I always have a talk with them to see how like pain has, how this problem they're coming into, pain or feeling old or, what have you, how that has impacted their life, so it's, usually things like, oh, well, I like to go on walks on the weekend with my wife or my family, or playing, I can't get on the floor playing with my kids, things like that. So I want to talk about movement in a meaningful way with them, because if the movement's not meaningful, then they're not going to make that connection. So first we have to make that movement or that goal meaningful. I always ask them, what movements do you feel safe in? So what do you feel that you can do? So somebody might say, oh, well, I can squat, but I can't pick up some, or I can squat, or I can walk, I can, do whatever. So I make a list and I write it down for them and say, well, these are the things I feel safe doing. And then I ask them, well, what don't you feel, what creates danger? So there's safety in me and there's danger in me. So I ask them, what's dangerous, what you feel you can't do that you would like to do. So if I'm working with a weightlifting athlete, it might be like, well, I can't do a deadlift because without my back hurting. I can't do a lunge, or I can't do a push press overhead, or what have you. So then I sort of I write down the safety in me, I write down the danger in me, and then I say, okay, what we want to do is we want to take these things that you don't feel comfortable doing, and I want to move them over, to the safety in me list. And then I might pick a little something. Okay, so you say you have difficulty squatting, or let's say you have difficulty deadlifting. So we're going to think of some progressions for you to be able to deadlift. So over the next week, I'm going to give you just a little bit of homework, and it might be, doing a partial deadlift from a rack to start, and then slowly getting them to sort of they can bring it to the floor. So I'll just set little realistic goals every week that, that they can achieve, because they see everything as this big thing, like I can't pick up this heavy weight off the floor. So as long as you explain like the steps and the graded exposure, and just give them small things to start out with, and it's important that first, can they perform the movement? But then in the beginning, some things might be painful, and that's okay. That's going to happen. But sometimes that's your body's, your brain's way of trying to feel, is this safe or not? But then once they get a little bit of success and say, oh, well, I did some rack pulls this week. They feel I can do them without pain. I'm like, okay, so we're gonna bring the next step. And the next step might be 2 like kettlebells off the floor. So we might do that. Make them feel safe in that, and then eventually we'll work to that barbell deadlift, and then those things in the danger in me column are going to slowly move to the safety in me. So then we're going to pick off other things off that and just, keep on moving things over. As long as the most important thing is graded exposure. I think that people feel that, let's say they were running marathons and now they can't run at all, that they're not going to get that success until they're running that marathon again. We need to put, little steps, in between. But then in terms of movement and different things is make sure they're not comparing themselves to the best mover in the room. So everybody has their unique sort of path or unique sort of body map, based on past activity, injuries, and things. So it's just a matter of working that person, the individual, and not the same things are going to work with with every person. So just think on your feet a little bit.
Yeah. Oh, that's great. That's perfect. So in terms of movement, in general, on average, what do you find to be the most restricting movement pattern? For example, I've been I've been noticing a lot that a lot of my clients have a problem with hip internal rotation, and mainly because most of them have like duck feet or outward-rotated hips. So I have a difficulty getting them into hip internal rotation. So have you noticed any kind of pattern that you can see in most people?
I mean, and definitely the the hip mobility issues, like you mentioned, but also, yeah, especially from the first lockdown, as I've noticed, yeah, since we're like this all the
Yeah,
time, but that I think it's that brachiation, but then also ultimately being able to brachiate under load, so as humans, we should be able to hang, naturally, but that's not something that we do. So I know I struggled myself because first lockdown, I was out of the gym, and I wasn't able to do the, pull-ups and, muscle ups and toes to bar and things like that. And I didn't realize how important that was until the first time I tried to snatch after lockdown, and holding a bar over my head was
like a jelly.
yeah, it felt very foreign. Not only was I tight, but it just was not stable at all. So I mean, we spend most of our lives like this, but then people go to their classes, whatever it may be, my Pilates class, yoga class, or CrossFit class, and then for an hour they try to get like this, and it's very difficult because whatever you do the most, your body's going to adapt to that. So brachiation is probably the most one of the more difficult things for most people because of our flexion-based society, especially now where everybody's on their laptops, everybody's on Zoom, and things like that. So that's definitely going to have an impact on things.
Perfect. And great. It's been amazing. So I've got one last question and we're done.
Yeah.
So in terms of fascia, and I'm not going to say myofascial release,
Yeah.
I'll just say fascia treatment.
Mm-hmm.
Where do you think things going from now on?
So I think research is going to go a little bit more toward the neurological component of fascia. I think the brain connection, not only to fascia, but the treatment of pain, especially chronic pain, and how lack of movement decreases input, which ultimately affects output. But then also the fluid dynamics of fascia. I think there's more to things that has been expressed in the literature. So I think those are sort of like the two areas that I think the research is going towards. The only like sort of critique I have with some of the things that are on social media is the fact that because not a huge amount has been proven via the research and fascia, a lot of people aren't willing to say that it's not important. So I'm hoping that in the next 5 to 10 years that body of research will increase and hopefully open people's minds to it. I used to think of fascia mostly as a mechanical organ, and I was breaking up adhesions and things like that. And then I as the research has evolved, I've sort of figured out that was wrong. But it just sometimes takes a little time for these thoughts to evolve and then eventually be proven in the literature. But then we'll probably be surprised by things, and some of the things we don't think are true, might not be true. So I think it's just about really being agile in your thinking, and not like tying yourself down, and just being open-minded, as the research evolves, or as your experience as a practitioner evolves.
Yeah. So are you aware of? I'm sure you're aware of Kelly Starrett.
Oh yeah, Kelly Starrett. Yeah.
Yeah. He does a lot of fascia work. But there's also a doctor called Andrea Ospina.
Oh yeah, I know Andrea Ospina. Yeah.
Yeah. So to me, watching
Mm-hmm.
it from the outside, it seems like they have a different approach. So Andrea Fina is more movement-based, trying to insert movement into restricted areas, while Kelly Starrett talks more about sliding, braking. So what do you think about that? Are they talking about the same thing, or are they just approaching it from a different angle?
I mean, I think we're all talking about the same thing, and I think we're all evolving. And I'm a big fan of Andrew Spina's work in functional range conditioning and everything. I am, and I'm a fan historically of Kelly Starrett, and mainly because within CrossFit, he has sort of taught people how to body maintenance, outside of your regular workouts is important. He's softened quite a bit the last few years in terms of he used to talk about breaking stuff up, and using balls and bands, and things like that. But he's talking a lot more about sort of the neurosensory effect of everything, and less about the mechanical deformation of tissue. So he's since evolved quite a bit. I think but I admire him because he created a large body of people who are willing to do body maintenance. But I mean, they're generally trying to accomplish the same things. So I mean, I've changed a lot from when I was in chiropractic school. It was all about manipulating, taking pressure off nerves, and moving bones and things like that. And we found out that that isn't exactly what was happening when we're manipulating the spine and things like that. So I think we're all on the same sort of path, but I think it's really important that no matter what your beliefs are at a given time, you might be presented with data or research or whatever that might need to change things a little bit.
Awesome. Well, I did a workshop with Kelly in Amsterdam 2016. Mm-hmm. Very interesting stuff, but I think you're right. He's slowly starting to change more out of that early braking, pushing pattern. Well, thank you very much for your time. It was amazing.
Thank you.
A lot of my questions went through.
Okay.
And just to finish, where can people find you in terms of care or workshops?
Yeah, you can find me on Instagram at rockdocrob, ROCKDOCROB. And I practice in two places. First is at Gain Fitness in Norwich. You can book in at gainrecovery.co.uk. And the other, and I work 1 to 2 days a week in London at P10 Fitness at Elephant and Castle. So those are the two places that you can find me. You could always just drop me a message on Instagram, and I can get back to you.
Awesome. Thank you very much for your time.
All right.
Have a lovely day further. Nice to meet you.
Thank you, Robert. Okay. Bye.
Bye.